Hello, hope you all are doing well. Welcome back to my YouTube channel. Today I'm going to discuss another MCQ with you all. You all know that this is regarding AMC exam preparation MCQ discussion. Okay, let's move on to this MCQ. This is a 65 years old female patient who was prescribed amoxicillin for 7 days as she is having a upper respiratory tract infection. So they have given the MCQ like this, and then they have mentioned that she developed severe watery and mucoid diarrhea after 2 days of treatment, and these symptoms persist along with the cramping abdominal pain associated with frequent urgent call to stool, fever and nausea. They are asking what is most likely diagnosis. They have given 5 stems: ischemic colitis, necrotizing enterocolitis, pseudomembranous colitis, ulcerative colitis, shigellosis. There is a spelling mistake. That should be a pseudomembranous colitis. Okay, now you all know this is antibiotic related diarrhea. So for this MCQ, the answer is pseudomembranous colitis. I have discussed about the pseudomembranous colitis previously. Today I am going to discuss regarding ulcerative colitis. That is also a main topic that came for the MCQ in almost every year, because that is a common topic that they are questioning about. And in this video you can get all the knowledge about ulcerative colitis that need for the MCQs. So you do not need to refer any books. Just by watching this video you can get all the knowledge. Okay, let's move on. What you know about ulcerative colitis? Ulcerative colitis is a type of inflammatory bowel disease. So what is this inflammatory bowel disease? There are 2 main types. One is ulcerative colitis, other one is Crohn's disease. If we get MCQ with Crohn's disease, I will discuss about this. Today we will see ulcerative colitis. There is 2 main things you should know. What is flare? Flare is a new damage. Remission is a tissue heals. These 2 words going to use repeatedly. And ulcerative colitis affect mucosa and submucosa of large intestine, and this is a circumferential and continuously affect the mucosa. This is an autoimmune type of disease where T cells affect our own body cells. That is the mechanism what we believe for the moment. So when we consider about the pathophysiology, actually this is a type of inflammatory bowel disease. Ulcerative means ulcers, colitis means inflammation of the colon. So by the name itself you can get an idea that this is a ulcers and inflammation of the colon. So if you want to note down, pause the video and you can note down. If this speed is very low, you can increase the video speed. I am doing this speed so everyone can understand properly. If you need that I need to improve my videos, please comment below and subscribe my channel. So this is the pathophysiology. There is a continuous area of inflammation, mainly in the rectum plus colon. So what happened to this mucosa? This mucosa become inflamed and friable mucosa with crypt changed, and there is a reduced globular cells and pseudopolyps will be there. And you can note here submucosal inflammation and ulceration if severe disease is there. Usually it affects mucosa. In severe disease, submucosa also can be affected. When we consider about the epidemiology, prevalence is usually 1 in 1000, and this is bimodal onset. Most commonly affected age group is 15 to 25. We commonly take as 20 to 40 because 15 to 25 years commoner and old age 55 to 65. So if we get a median value, that should be 20 to 40 is the we consider as the commonest age of onset of the disease. And if someone get a disease, there is a more always there is a recurrence of the disease, that what we call a flare, and most of the time need lifelong treatment to prevent relapse and continuous the remission of the disease. And both ulcerative colitis and Crohn's disease, regarding the sex between the male and female, there is no much difference, that more common in female and more common in male. Like this, equal sex incidence is there and can occur at any age. Peak onset is 20 to 40 years. Can occur at any age, but peak is 20 to 40 years. When we consider about the prognosis of the disease, in active flare, the mortality is 5% mortality is there. So this is considered as a medical emergency because of this high mortality, and recurrent attacks are common. So this is a lifelong disease. Signs and symptoms, mainly what are the things that patient come and complain are as name itself, it is ulceration of the colon with inflammation. So main function is colon is water absorption. What happen in this condition is that water absorption is not happen properly. So more water in the stool, that calls diarrhea, and most people have blood in stool. 75% blood will be there in the stool and may contain mucus, and they have low abdominal cramps, rectal symptoms there, urgency, tenesmus will be there, and relative to Crohn's, it is more likely to present gradually. I think you know the meaning of urgency and tenesmus, and blood is mainly due to the ulceration of the mucosa and submucosa, and as this mostly affected mainly affect lower part of the colon, patient can present it with blood and mucus diarrhea. So when someone losing lot of water from the body, they can have at the same time dehydration and electrolyte imbalance. You should consider when patient present with these symptoms. Usually ulcerative colitis begins in the rectum and continuous proximally affect only colon. Usually this does not affect after ileocecal valve. This does not spread beyond ileocecal valve. Hope this is clear for you all. And if we have continuous disease for more than 7 to 10 years, there is an increased risk of malignancy. In attacks, patient can have tender, distended abdomen. Patient can complain fever. At the same time, patient can have anorexia. Because of anorexia, there may be weight loss, and this can also triggered by infections. Okay, what are the signs? Non-interstitial ones are in eyes. There can be uveitis, episcleritis, and conjunctivitis most commonly. And there can be aphthous ulcer through much less than Crohn's. Aphthous ulcer is more common in Crohn's disease. There can be clubbing, which also more common in Crohn's disease, and there can be skin manifestations such as erythema nodosum and pyoderma gangrenosum. And musculoskeletal, there can be enteroarthritis, usually affect large joints such as knee joint, and axial arthritis such as ankylosing spondylitis. This point I already mentioned. Clubbing and aphthous ulcer more common in Crohn's disease. The MSK symptoms, joint pain, swelling or muscle pain, they can have due to arthritis, myopathies and metabolic bone disorders. And if the patient complain lower back pain and relief of the symptoms with exercise, you have to think about whether the patient is having ankylosing spondylitis. Then, usually joint symptoms more common, affect 25% of all patients compared to axial arthritis. That means ankylosing spondylitis. Peripheral arthritis is more common. And the presentation increases with the colonic involvement. This is what we call erythema nodosum. You can pause the video and watch the image if it is not clear. So, what is this erythema nodosum? This is painful, and this is raised subcutaneous lesion in extensor surfaces of extremities. Mostly 3% of patients, more commonly affect female more than male. Ulcerative colitis patients almost always have lesions on the anterior surface of the lower limbs. Mirror ulcerative colitis disease activity and worsen with flare. If the disease is worsened, there can be erythema nodosum. Average lag time between diagnosis of the disease and appearance of the erythema nodosum is usually 5 years. What is this? This is pyoderma gangrenosum. We will see what happened in the pyoderma gangrenosum. This is a necrotic ulcer with expanding borders. You can clearly see in this image what this look like, and usually on legs, but can affect any part of the body, anywhere skin can get affected. Okay, what is this? This is a aphthous ulcer. Usually the aphthous ulcers which occurs are mild in nature, and usually these are resolved within 6 weeks time like. And these are small, round, painful. Usually heal within 2 weeks, maximum 6 weeks. But if this extend more than that we call major recurrent ulcers. Larger, these are very larger and can last for up to 6 weeks and beyond. This is what you think this is. You can clearly see the image. This is episcleritis. Episcleritis usually inflammation of the bilateral and segmental, and there is no associated visual impairment or purulent discharge. Patient can complain of eye discomfort, irritation, redness and tearing. Okay, let's move on to next image. This is uveitis. More common with ulcerative colitis. You can see clearly the difference between healthy eye and how the eye with uveitis look like. And uveitis, there is a visual features are there. Patient complaining of photophobia, blurred vision, pain, and conjunctival ingestion will be there. So we will move on to next slide. What is this? I'm waiting for you to give an answer. Think and give an answer. That's why I'm waiting. So what is this? This is scleritis. Deep eye pain. Patient complain very deep eye pain which radiate to eyebrow, cheek and temples of the face. And there will be redness, tearing, photophobia, and patient also complaining of blurred vision. Severe cases can lead to blindness also. So, in ulcerative colitis, the more common eye presentations are episcleritis, uveitis, and conjunctivitis. And eye involvement is more common in female than male and correlate with ulcerative colitis flare. And there can be hepatobiliary signs. Patient can have primary sclerosing cholangitis, chronic hepatitis, non-alcoholic fatty liver disease, we call this as NASH, and cirrhosis. So that's important. You should look on liver enzymes, whether there is any liver involvement. What are the risk factors? These are the most commonly asked areas in the questions. So risk factors are not smoking. Actually, less common in smokers. Next one is family history. Family history is a risk factor. Third one is HLA B27. Fourth one is previous attack. And fifth one is low fiber diet. So these are the mainly identified risk factors. This can ask in the MCQs. So how are we going to investigate if the patient we suspect to have ulcerative colitis? From the basic blood investigations, I'm going to discuss with you the very higher end investigations also. There will be high CRP and high ESR in active disease. These are inflammatory markers. You know that, no? So also there is an increase in the other inflammatory markers that are, there will be high platelet, and that is thrombocytosis, and there will be low albumin. Next one is investigations continued, and 1/3 of the patient is having anemia. Usually if we check the blood picture, that is anemia of chronic disease or iron deficiency anemia. Less commonly, there can be B12 and folate deficiency also. Then still I am discussing about the investigations. Next investigation, and at the same time you should look for the urea and electrolyte. Electrolyte is so important to check, and if facility is available you should check for magnesium and calcium levels, because patient obviously can have nutritional deficiencies and electrolyte imbalance. And you have to check for the liver function test, look for any associated hepatobiliary disease. Then investigations continued. We're going to look for the immunological ones. We can look for P-ANCA, which is positive in 70% of ulcerative colitis, and ASCS 70% in Crohn's. What is P-ANCA? Perinuclear antineutrophil cytoplasmic antibody. What is ASCA? Anti-Saccharomyces cerevisiae antibody. So usually we are not doing this immunological investigations. If facility is available, you can consider. Then other investigation is you should do the stool investigations. Those are, you have to do the culture to look whether there is ongoing infection, and you have to do for the fecal calprotein. This is very sensitive test. 93% sensitivity is there, and 96% specific for inflammatory bowel disease. Also, if facility is available, you can look for whether there is a Clostridium difficile toxin presence. If this is positive, that simply means prognosis is poor. This is a poor prognostic marker. Then investigations continued. Then these are more higher end investigations. You have to do the endoscopy with biopsy. You can do the sigmoidoscopy is usually sufficient, because ulcerative colitis mainly affect the rectum and the lower down of the colon. We are going to do colonoscopy if poor response to treatment. Endoscopy shows mucosal granularity, and biopsy show crypt architecture changes, including cryptitis and crypt abscesses. So visually we are doing proctosigmoidoscopy. We do the proctoscopy plus sigmoidoscopy. You can see what you can see is a granular red proctitis with contact bleeding. We are using the flexible sigmoidoscopy. In mild disease, you can see loss of normal vascular pattern and a granular texture will be there, and there will be microhemorrhages, but these hemorrhages happen when we touch the mucosa only. Moderate disease, their mucosa grossly pitted and there will be spontaneous bleeding. Spontaneous bleeding is not there in mild disease. And in severe disease, what you can see is macroulceration will be there and profuse bleeding will be there. Also at the same time you can see there is a purulent exudate. So still I am discussing about investigations. You can do abdominal x-ray, which is may show perforation or gross dilatation in a flare up or toxic megacolon. Toxic megacolon means transverse colon diameter dilatation more than 6 centimeters. Barium enema you can consider, but usually because of the high side effects, we are usually not using this. What is the management? This is the important part. So there is a medical management and there is a surgical management. In attack, we need to assess the severity. We are using a score for that, what we call that is True Love and Witt's criteria. Let's see what is this criteria and how we differentiate the disease into mild, moderate and severe. So our target in management is induce remission. This is the criteria. Mild means frequency of defecation 4 times or less, bloody stool plus or minus, and all other things absent and ESR normal. Severe disease means frequency of defecation 6 times or more, bloody stool plus and patient will have fever 37.5 or higher, and tachycardia will be there more than 90 beats per minute, and patient will have low hemoglobin level, usually HB less than 10, and ESR will be high. This is the severe disease. So anything intermediate to these things, if these all fulfill, that consider as severe disease. And in mild disease, frequency of defecation is 4 and no plus or minus bloody stool and all other things absent. Depend on this criteria, we divide the disease into mild, moderate, severe. Treatment, there is a 3 main target. First one is anti-inflammatory. We are using sulfasalazine, mesalamine like anti-inflammatory drugs. Then we do immunosuppressors. Immunosuppressors we are using are corticosteroids, azathioprine and cyclosporine. And we can use biologics, infliximab, golimumab, adalimumab. And also at the end we can go for a surgery, that is colectomy in severe and refractory disease. In a mild to moderate flare, what we're going to do is, first line is mesalazine PR if distal, that means affecting descending colon and rectosigmoid, plus per oral if proximal or refractory. Second line is added prednisolone per oral plus or minus per rectal, and mild to moderate disease patient we are managing as outpatient. Next one is the severe disease. This is a medical emergency, so we need to admit, always need to admit, and we have to give IV corticosteroids. At the same time, if there is a poor response to IV corticosteroids, we will start on cyclosporine and we will consider giving biologic. If severe refractory disease, you have to consider subtotal colectomy. As I previously mentioned, this is medical emergency. You should consider your A, B, C, D, E. You should give IV fluid and blood transfusion if patient having low HB. If you are suspecting any ongoing infection, we will start on antibiotics. It is most important to give nutritional support, and also we are giving subcutaneous heparin to prevent venous thromboembolism, and we are not going to give opioid and antidiarrheal which can cause obstruction and worsen the disease. And IV cyclosporine or infliximab given to stable patients who are not responding to IV steroids. After 3 to 5 days of treatment, we will consider whether we are going to give these or not. Okay, then after we manage the active flare, what is important is maintaining remission. For maintaining, main first choice of drug is mesalazine per oral or per rectal. If it is rectosigmoid, we consider per rectal. First line after mild to moderate attack, and azathioprine or mercaptopurine per oral. First line after a severe attack or if steroid needed twice in a year. These are our drug of choice. And you should know that mesalazine and sulfasalazine. Sulfasalazine is the previously commonly used drug, but the side effects are more common with sulfasalazine rather than compared to same drugs in that group, that is aminosalicylate. Their action is they modulate the cytokines released from the mucosa. Okay, let's move on to biologics, what we are using for the treatments, and Janus kinase inhibitors. Biologics are used to induction and maintenance in refractory moderate to severe disease. Anti-TNF alpha 1s are infliximab, adalimumab and golimumab. Other agents we can use vedolizumab, that is anti-alpha 4 beta 7 integrin, and tofacitinib. These are anti-JAK1 and JAK3. Okay, now we move on to when we need this surgical management. Why we need this surgical management? There is an indication where we have to go for a surgical management. Usually surgical management needed in 30% of patient. Indication: medically refractory chronic or acute ulcerative colitis. Second one is toxic megacolon or perforation. Third one is dysplasia or malignancy. In these conditions, we need to go for a surgical treatment. we can go for elective surgeries and also emergency. Elective ones are proctocolectomy with ileoanal pouch anastomosis or end ileostomy. Ileoanal pouch avoids the stoma but is technically harder and carries high morbidity. In terms of functional and quality of life outcomes, the pouch is formed from several loops of ileum which are sutured side to side. If we made an ileoanal pouch, what are the complications that can occur? Pouchitis, which is more common in 50%, and nocturnal seepage can be there in 15%, urgency in 10%, impaired fertility in female because of the adhesions formed. Impaired fertility in women due to adhesions formation will be there. And pouchitis present with loose and frequent stools, and we usually treat it with metronidazole. And this is an emergency surgery we are doing in subtotal colectomy, sparing the rectum with end ileostomy and long rectal stump. And you can consider ileorectal anastomosis also. What are the complications of this acute surgery? Patient can go into sepsis, and poor healing will be there because these patients are already on prolonged corticosteroid, and those are very high dose of steroids which cause immunosuppression, which prolong the process of healing. Okay, next we move on to complications of this ulcerative colitis. First complication is perforation, which is worst case scenario, and there can be toxic megacolon, and there can be colorectal carcinoma. So if any patient is having ulcerative colitis, you should screen them with colonoscopy to look for the patient is going to develop colorectal carcinoma. Frequency is usually every 3 years we need to do this. Usually carcinoma occurs 10 years after onset of the disease, and if there is a carcinoma, management will be definitely surgical, and we consider removal if dysplasia found. And there can be venous thromboembolism. Because of that, I mentioned previously, we are giving heparin in active flare to prevent venous thromboembolism. Okay, now we're going to describe in last few slides the difference between ulcerative colitis and Crohn's disease. Ulcerative colitis only involves colon from the name that mentioned, while CD, that is Crohn's disease, involve any part of the GI tract from mouth to anus. Ulcerative colitis, pain usually in the left lower abdomen, while when Crohn's disease, pain is in the right lower abdomen. Also is wrong. Crohn's disease, colon wall thicken and rocky appearance will be there, In ulcerative colitis, colon wall thinner and continuous inflammation will be there. Crohn's disease, ulcers deep and extend into all layers of the bowel wall. When compared to ulcerative colitis, mucus lining of the large intestine may have ulcers but do not extend beyond inner lining. And Crohn's disease, PR bleeding is not common, but ulcerative colitis almost there will be PR bleeding. These are MCQ points. This also explains the same things. You can see these two diagrams. Crohn's disease affect any part of the GIT, discontinuous patchy inflammation, and transmural affect the full thickness of the bowel wall. Ulcerative colitis affect only large intestine, continuous inflammation, mucosal and submucosal layers affected. So, full thickness is not affected in ulcerative colitis. This also shows the same diagram how the ulcerative colitis and Crohn's disease affect the GI tract. Now we move on to the difference what we can see in the sigmoidoscopy. Crohn's disease location inflammation frequently affect the mouth, distal ileum and colon. Primarily affect the sigmoid colon in ulcerative colitis. Histology transmural in ulcerative colitis, mucosal patterning, mucosa and submucosa. Pathology discontinuous patchy inflammation with skip lesions. Ulcerative colitis, continuous inflammation from the rectum to proximal part of the colon. Complications, stenosis, abscess formation, fistulas and colon cancers in Crohn's disease. In ulcerative colitis, severe bleeding, toxic megacolon, bowel rupture and colon cancer. You can see in Crohn's disease, fistulas are not common. These all are MCQ points. This also same thing. The difference is ulcer in the Crohn's disease is serpiginous and ulcerative colitis long ulcers broad based. Pseudopolyps Crohn's disease rare, ulcerative colitis common. Fibrosis common in Crohn's disease, rare in ulcerative colitis. Fissures and fistula common in Crohn's disease. We can't see those in ulcerative colitis. Inflammation usually Crohn's disease, as I mentioned, it is transmural. Ulcerative colitis, mucosa and superficial submucosa only. And granuloma seen in the Crohn's but not seen in the ulcerative. And already said fibrosis common in Crohn's disease, usually absent in ulcerative colitis. So